Well, we finally made it out of obstructive lung diseases. Obstructive disorders, remember, are characterized by decreased airflow out of the lungs. Air gets trapped. That left us with increased lung volumes on spirometry, like total lung capacity and residual capacity. Throughout this next chapter, we're going to see quite the opposite. In restrictive lung diseases, you can't get air in the lungs due to a decreased ability of the lung to expand. As we'll soon illustrate, this can either be an internal restriction, like a fibrosing lung disease making the lungs all scarred and non-compliant, or we have an external restriction, like obesity weighing down the chest wall, or a pleural plaque, or a tight, restrictive corset. Yeah, let's face it, Victorian-era England was restrictive, to say the least. Restrictions on women's rights, kids restricted to working in factories, people rushing into crowded cities after the Industrial Revolution. This is our restrictive lung disease overview sketch. We'll cover the basic clinical presentation and physical exam findings that characterize the restrictive lung pathologies, like idiopathic pulmonary fibrosis, pneumoconiosis, and sarcoidosis. Then, in the rest of the chapter, each etiology will be covered in much more detail. Get ready for some spirometry readings as well. It's pretty much what you'd expect in a lung that can't expand. Volume goes down. And when the lungs can't expand without using much more pressure than usual, that means reduced lung compliance. Just take a look at our young protester out there, tearing up his contract with the local factory. What is he, like 10 years old? And he's already got the black lung? Child labor. You make me sick. Now, to really define restrictive lung disease, we need to look at pulmonary function testing, the first component of which you might be familiar with, spirometry. This is where the respiratory therapist screams at the patient to take a deep breath in and then blow out as hard as you can, while the patient has his or her mouth sealed around that spirometer thingy. As the patient exhales fully, we're able to measure all kinds of things, like flow rates and lung volumes in reserves. Residuals, maybe? It's a little much, honestly. So we're just going to focus on the spirometry results that pertain to restrictive lung disease and really help you nail that diagnosis. All right, so if my lungs are all restricted and stuff, then what you're going to measure is a decreased total lung capacity, or TLC. TLC is a measure of all the air in a fully expanded lung. In other words, take a huge breath and hold it in. How much air is in your lungs? That's your TLC. People with restrictive lung disease just can't take that huge breath in because their lungs are non-compliant. So down goes their total lung capacity. In this scene, decreased total lung capacity is represented by that overturned total load capacity. Because in the late 1800s, nothing got your point across more than throwing old vegetables around. Hey, women should vote. Radish! Hey, schools should be better. Eggplant! For our next set of spirometry values, take a look at the banner held by the angry crowd outside. On the top, we've highlighted FEV1, which stands for the forced expiratory volume in 1 second. Underneath is FVC, which stands for forced vital capacity. We're going to be looking at the ratio of the two, FEV1 over FVC. Think of it like this. Take a full, deep breath in and then blow out as much as you can as quickly as you can. The amount of air that you exhaled in the first second is your FEV1. The total amount of air that you exhaled is your FVC. You typically blow out a majority of exhaled air within that first second. So, the ratio of 1 second exhalation over total exhalation, or FEV1 over FVC, is normally about 80%. We've made these values elevated above the crowd, specifically the ratio of these values elevated, because the FEV1 over FVC ratio usually stays near or above 80% in the setting of restrictive lung disease. Here's why. Patients with restrictive lung disease just can't inhale fully. Their lungs just aren't compliant enough. So they're not going to exhale as much either, and their forced vital capacity actually remains relatively low. So as that FVC sign kind of swings down like that, Imagine that ratio staying high. Also, you see how that FEV1 banner is stretched tight? This pertains to interstitial lung diseases specifically, which cause pulmonary fibrosis and stiffening of the pulmonary interstitium around the airways. This causes airway widening. Again, imagine everything around the airways is all elasticy and stiff. This increases radial traction, pulling outward on the sides of the airway in all directions. So, just like the traction on this banner pulls it open, a restrictive lung pulls those airways open. This actually decreases the resistance to expiratory flow, and the patient is able to get more out in 1 second than you'd expect with those small fibrotic lungs. Overall, while FEV1 is decreased, it doesn't decrease that much. And it decreases way less than that FVC down there. That's for sure. This helps that FEV1-FVC ratio stay high. The last value I want to mention is functional residual capacity, or FRC. FRC is the volume of air that is present in the lungs left over after a normal exhale, not a forced exhale. Just your normal exhale, like what you're doing right now. As you can tell by that tipped over cart, when you've got small restricted lungs, your total lung capacity is low. And so is any residual you thought you were saving in there. You're just not going to have much air left over after you exhale. You know what though? Before you even strap that spirometer on your patient, there are some key clinical and radiological findings that should already be cluing you into a diagnosis of restrictive lung disease. Most of these findings are going to pertain to the diffuse parenchymal lung diseases covered throughout the rest of this chapter. These are collectively referred to as interstitial lung diseases. That means the pathology is occurring inside the lung, usually some kind of combination of inflammation, fibrosis, and scarring. Let's go through a few classic symptoms. First of all, disease usually develops insidiously, with the gradual onset of non-productive cough. So as that corset gets tighter, out comes that persistent dry cough. Also, you see that uncomfortable breath let loose by the maid as she struggles with the corset? This is to remind you of dyspnea. Early in the course of disease, dyspnea will occur during times of exertion. As the disease progresses, however, patients can have difficulty breathing even at rest. Take a listen to those lungs as well. In most forms of interstitial lung disease, you should hear some dry crackles, usually described as Velcro rails. Just think of these Velcro straps down here, ripping apart after taking a big, deep breath in. When listening for crackles, it's helpful to listen at the lung bases, as crackles may show up here first in early disease. Next, let's talk chest X-ray. Remember, whenever we want to highlight important findings on chest radiograph, we'll include an X-ray Jolly Roger, like this one here. With interstitial lung pathologies, you'll most commonly see a reticular pattern. Nodular or mixed reticulonodular are common as well, so we've incorporated a reticulonodular pattern into that restrictive corset. See? It's a reticular net-like pattern with nodular knots. These findings are usually diffuse and bilateral. Oftentimes, the disease is most significant in the upper or lower lobes, and we'll try to convey this visually for each individual disease throughout this chapter. These opacities, when seen on CT, are sometimes called ground glass opacities or shadows. It's not a very specific finding, and let's face it, radiologists like to apply it to kinda any hazy, shadowy thing. So just watch out for that term in the question stem. In advanced disease, patients can develop full-on respiratory failure, often with associated pulmonary hypertension. You see, prolonged interstitial lung disease causes destruction of lung parenchyma and a reduction in alveolar capillaries. As a result, pulmonary arterial resistance increases. See how tightly she's pulling on those pulmonary arterial ribbons in the back there, increasing the tension? What you're left with is elevated pulmonary arterial pressure. Be sure to check out our pulmonary vascular sketch for a more in-depth discussion of the pathologic mechanisms underlying pulmonary arterial hypertension. All this tension is felt by the right heart, which now has to work harder to move blood into the lungs. Eventually, This can lead to right heart failure. Anytime a lung pathology causes pressure buildup and right heart failure, this is called cor pulmonale. And at Sketchy, it's represented by a cork putting a plug on the heart. You can expect the usual right-sided heart failure symptoms to follow, including JVD and peripheral edema. Okay, let's back up a bit. So far, we've been focusing on the clinical presentation of interstitial lung diseases. Remember, this is when the pathology is inside the lung itself, causing inflammation and scarring of the parenchyma. Restrictive lung disease, however, can occur from pathologies outside the lung as well. This is called extrinsic, rather than intrinsic, restrictive lung disease. These disorders still involve decreased lung compliance, making it difficult to take a deep breath, but this time there's nothing wrong with the lungs themselves. Let me show you what I mean. All right, let's see here. We have to think outside the lungs. Something is making it so those lungs don't want to expand. I know. Take a look at the governor's vest. See that chain? Hanging on for dear life? Making sure his chest doesn't expand? Think of that vest as a set of restrictive pleura that encase the lungs. In the setting of pleural disease, such as mesothelioma, pleura can develop plaques and stiffen. Or, during pleural effusion, for example, fluid can collect between the parietal and visceral layers, making it so your pleura just don't want to move. Either way, the lungs underneath will not be able to expand as they should. In other words, they're restricted. Hey, how about this for a restrictive lung disease? What if you just can't breathe? As in, your diaphragmatic and intercostal muscles just aren't working and your lungs won't expand? This can occur in the setting of neuromuscular diseases such as polio or myasthenia gravis. Just think of this butler here, trying in vain to warn Parliament of the impending working class revolt. See how muscular he is, by the way? Not only that, look closely and you'll see that the telegraph wire is cut. Let it remind you of impaired neuronal signaling to the muscles of respiration, thus leading to an extrinsically restricted lung. Poor breathing mechanics can also arise when the bony structures surrounding the lungs are malpositioned. The major pathologies to know here are kyphoscoliosis and ankylosing spondylitis. See that curved spondylitis spine carved into the side of the chest? It turns out that when the spine is malformed or fused, it can actually limit the expansion of the entire chest wall. That's why we put a lock on this chest of drawers. Think of it as a lock on your patient's chest, preventing full expansion of the lung. Morbid obesity can lead to a similar scenario. Notice that we've added some extra girth to our concerned governor here. All that excessive extrathoracic soft tissue limits chest wall expansion, leading to a restrictive lung disease. So watch out for that patient with significant central obesity who presents with chronic mild dyspnea and fatigue, especially if he has no other history of pulmonary disease. In the question stem, they'll also throw in a BMI over 30. Yep, that means obesity. And they might also report that his respiration rate is around 20. 20 is pretty high. Just think of the governor here, breathing rapidly into that bag, trying to come to terms with the fact that he might be out of a job soon. Obese patients compensate for reduced chest compliance by increasing their respiratory rate. So they're breathing faster, but the breaths are small because their lungs are restricted. If they ask you what kind of spirometry readings to expect, remember that FEV1, FVC, and TLC are likely to be reduced in the setting of a restrictive lung pathology. And this is true for all of the intrinsic and extrinsic diseases covered in this sketch. However, these changes will probably be modest in the setting of obesity-related lung restriction. The most common indicator of obesity-related disease is a reduction in expiratory reserve volume, or ERV. Instead of expiratory reserve, just think of the governor's extra reserves here, depleted. Expiratory reserve volume is the maximum amount of air you can breathe out after a normal tidal expiration, and obese patients just don't have much reserve left. Now, I want to bring your attention back to that bag he's breathing into. I also want it to remind you of retaining carbon dioxide. Just imagine constantly rebreathing the same air over and over in that little bag. Because here's the thing. Obesity in the long term can cause what's called obesity hypoventilation syndrome. Hypoventilation means you're not breathing off CO2, so you can expect a chronically elevated arterial partial pressure of CO2 with an accompanying reduced partial pressure of O2. In other words, high PaCO2 and low PaO2. We'll get into blood gases in a lot more detail during our hypoxia video. For now, just keep in mind that obese patients can chronically retain CO2, and that goes hand in hand with chronic hypoxemia. Chronic hypoxemia in the lungs causes the pulmonary vasculature to constrict. See how tight those pulmonary vascular chains are, holding his girth together? When this vasoconstriction persists, it will inevitably lead to irreversible vascular remodeling and pulmonary hypertension. Again, all this tension is felt by the right heart, eventually leading to right heart failure. Yep, as you well know, anytime a lung pathology causes right heart failure, that's cor pulmonale, putting a cork on your heart. All right, let's take a quick step back and take in the whole scene. On the left, we have a few extrinsic causes of restrictive lung disease: obesity, neuromuscular, and pleural disorders. Since the disorder lies outside the lungs, the pulmonary physical exam will actually be relatively normal. But wait, what about the dry cough and Velcro crackles and the reticulonodular opacities we mentioned earlier? Expect those findings in patients with intrinsic pathologies causing restrictive lung disease. These are often referred to as interstitial lung diseases, and they'll be the focus of our next few videos. We'll feature our recurring fibrotic pulmonary tree during our discussion of idiopathic pulmonary fibrosis. Then we'll head to the factory to learn about pneumoconiosis, diseases that are caused by the inhalation of mineral dust. And we'll finish up with granulomatous disorders, as embodied by that sarcoidosis soccer player. Though the underlying pathophysiology of each of these disorders varies, the outcome is the same. Inflammation and scarring leads to a fibrotic and restricted lung. Not only that, these disorders cause damage to the absorptive surface of the lung, and that's a key distinguishing factor between these intrinsic lung diseases versus those extrinsic diseases on the left. Only when the disease is affecting the lung itself will you be able to measure the decreased diffusion capacity of the lung. This is assessed by measuring the diffusion capacity of carbon monoxide, abbreviated DLCO. Any pathologic process that destroys or alters lung tissue will decrease the DLCO since it becomes harder for gas exchange to occur. At Sketchy, colorless, odorless, yet very hazardous carbon monoxide gas is embodied by those colorless, odorless, annoying soda can rings that evoke the image of trapped hemoglobin. And since DLCO is low for those intrinsic disorders we can see through the window, we've placed that carbon monoxide trash low in the scene, discarded and littering the ground. Yeesh, pretty dirty out there. And those rioters yelling about rights and stuff were kind of a downer, huh? Blah. Go back to your shanties. Am I right? Now that we know the basic workup of restrictive lung diseases, it's time to talk about each individual pathology in depth. First up, idiopathic pulmonary fibrosis. And for that, we'll need to step into my secret and excessively pretentious garden.